So we've been dispatched today to a 70-year-old male complaining of sudden onset chest pain. He is unable to stand due to dizziness and near syncope. He had a previous MI 5 years ago, so he has obviously a significant cardiac history. Upon our arrival, he's been sitting in a lazy boy recliner. He is pale, clammy, slightly confused, not really able to obey commands. He states that his heart feels like it's going to jump out of his chest, and that the pain he's experiencing at the moment is different to the pain that he felt with his previous MI. So we've gone ahead and laid him supine on the floor. We've taken a full set of vitals, so our blood pressure, SpO2, BGL, etc. So we've got a heart rate of 170, but we've got absent radials, so that was brachial heart rate. Blood pressure of 70/40, so he's severely hypertensive. A rest rate of 18, blood glucose levels of 7.6, and a temperature of 37. So I'm going to go ahead and pop on our leads and things, our 3 lead, and you do it, obviously do a 12 lead as well. So looking at our leads on our monitor here, we're just going to print a little strip and have a look. Okay, so it appears to be a broad complex tachycardia. Okay, so it appears to be VT, but we want to rule out SVT with aberrancy, so we can do that by looking at how broad our complex is. Also by looking at electrolyte imbalance as well, so with our questioning we've ruled out any previous vomiting or diarrhea or a history of being unwell, so unlikely that it's going to be an electrolyte imbalance. There's no evidence of a bundle branch block, and we're not getting any. We could also look for capture or fusion beats as well, which we haven't got on this ECG, but we can also look at precordial concordance as well to confirm VT. So because of his age and the fact that he has a previous cardiac history, we're going to treat this as VT. So we're going to call for an R50 backup, and we're going to need to cardiovert. Okay, so we've established that our patient is in VT with a rate of 170 to 180. He's severely compromised due to our decreased LOC, severe hypertension, so blood pressure of 70/40. We'd also be having a listen to his chest to see if there was any pulmonary edema present. He also has active chest pain, and he cannot obey commands. So because of that, he is status 1, conscious VT, and we need to call for R50 backup. So AUT1 calls control.
Go ahead, AUT1.
Can we get an R50 backup please for a status 1 conscious VT?
ETA 10 minutes.
Cool. Alright, so we've got our R50 backup en route. Now because this patient is dropping GCS and not obeying commands, we're going to cardiovert without any sedation. So obviously someone with a bit higher GCS, we would look at analgesia and sedation to cardiovert, but in this instance, being time critical, we're going to cardiovert without it. Okay, so we're going to flick through and find our lead with the highest R wave, which looks to be lead 2. So once we've found our lead with the highest R wave, we are going to turn our monitor to max joules, and we are going to put our monitor into synchronized mode. Okay, so we know we're in synchronized mode because we now have a detection symbol above all of our R waves. We're just going to print off a wee strip to make sure that we've got our detection symbols on our ECG strip, which we do. Cool. Now before I go any further, we're going to go through our checklist and make sure we've covered everything on our checklist. So we're going to make sure our pads are in place. So our pads need to be, we're just going to pop them on the chest because they're actual proper pads, not training ones. But our pads need to be in the apex sternum position, as well as our monitoring leads as well, which we've got on. We need to ensure that our defibrillator is in manual mode, which it is. We need to select the lead with the biggest visible R wave, and that artifact is minimised, which we've done. We need to select synchronised mode, which we've done. Confirm there's a detection symbol above every QRS, ensure the patient has received adequate sedation if indicated. So we've got IVs in case we need to, but we need to select our joules. So we've selected our max joules, which on this monitor is 200. We need to charge the defibrillator and make sure everyone is clear. So we're going to push charge. We'll wait till the monitor is fully charged. Once our monitor is fully charged, we are going to make sure everyone is clear again. We're going to push and hold the shock button until it says that our shock is delivered. So once our shock is delivered, we are going to reassess our patient. We're going to determine our rhythm. So it appears that our patient is no longer in a broad complex tachycardia. So he appears to be back into a sinus tachycardia. We're going to reassess our airway, breathing, circulation. So he is talking to me, so it appears his airway is patent. His breathing, he doesn't appear to be distressed or any increased work of breathing. He appears to have some colour coming back into him, so he's not quite as pale and clammy as he was beforehand. We're going to have a feel of his pulse, and it appears that we've got nice strong radials back as well. So we're going to do a full set of vitals, and if this patient wasn't reverted back into a sustainable rhythm, we could cardiovert one more time. Okay, so we've been today dispatched to a 40-year-old male who has fallen off a roof. I believe he was water blasting. We're querying whether he has slipped and fallen, and he has fallen 6 metres onto a concrete driveway and landed on his occiput. Our secondary survey has revealed a obvious boggy patch about 6 centimetres in diameter around the occiput. No previous medical history that we know of. He was found by his neighbour who called 111. She's unable to assist with us due to age and poor mobility. So at this stage we believe it's an isolated severe TBI to the back of this patient's head. He's laying supine. He appears to be posturing and extending. He's restless and combative, and he's moaning and groaning and appears to be breath holding as well. So because of that, I have given him a GCS of 7, made up of E3, V2 and M2, due to the moaning and groaning and extending. So basically what we want to do first is we're going to treat our TBI. So we're going to oxygenate to prevent secondary brain injury, and we are also going to get a full set of vitals as well to check blood pressure. So we've got blood pressure cuff attached, all our monitoring equipment. Our vitals have come back that he has a heart rate of 50. He has a blood pressure of 160/90. He has a rest rate of 12 and a regular. BGL and temperature are within normal limits. So at this stage we're not going to worry too much about fluids because he is maintaining a blood pressure above 120 systolic. But we are going to oxygenate to prevent that secondary brain injury. So first of all we're going to place a high flow reservoir mask on our patient just to oxygenate and prevent hypoxia. So our 4 H's we want to prevent is our hypoxia, hyperventilation, hypoventilation and hypotension. Okay, so we've deemed that based on our vitals and our GCS and our mechanism of injury that this patient is status 1 with a severe TBI. So we're going to request R50 backup and also an RSI officer as well. Okay, so AUT1 pulse control.
Go ahead, AUT1.
Can we get R50 backup and an RSI for a status 1 severe TBI, please?
ETA 10 minutes. Please prepare your patient for RSI.
Copy that. Okay, so we can also look at giving this patient some morphine for the combativeness. So that's something that we could explore. So gone ahead and prepared bilateral IVs. So if we needed to administer morphine, we could give morphine through one of those IV sites. Okay, so preparing for RSI, first of all we need to attach our nasal prongs, but not have them connected to oxygen. So we're just going to remove our oxygen mask briefly, put our nasal prongs here, we're going to pop our nasal prongs in, and tuck those on. We're then going to replace our reservoir mask to pre-oxygenate. So once we've done that, we need to attach all of our monitoring equipment, which we've done previously because we've had to take all of our vitals. So we've got our SpO2, we've got our blood pressure cuff attached, we have got our ECG monitoring leads attached, and we're also going to connect our end tidal CO2 ready to connect to the bag valve mask when ready. So we're going to have that there all ready to go. We're going to position the monitor where we can see it. So I've got my monitor positioned just to my right here so I can see that nice and clearly. It's close enough I can see it, but not so close that it's cluttering our scene. We're leaving a nice space to the right of the patient's head here for our RSI officer's intubation role. We've gained bilateral IV access, so one in the right and left ACF. We have a running line already ready to go, so we've got that all primed and ready, but not connected just yet. So we can have that connected, but just not running yet. So we don't want to be running too much oxygen when our patient's already got a systolic blood pressure of fluids rather, when our patient's already got a systolic blood pressure of 160. So we also want to maintain appropriate positioning of the patient's airway. So we do have a towel here that we can use to pop under our patient's head to maintain that airway positioning. And we also need to place an ETT holder under the patient's neck. So we're going to do that. And have that laying there ready for intubation. So we're also going to test our suction unit. Cool, so that's all working. And then we're going to have that laying on the left hand side here, just under the patient's shoulder or neck. So that's quick to access if we need to. So we've also got our bag mask here, which is prepared with PEEP and connected to running oxygen. And we're going to obtain another set of vitals to monitor our patient's vitals. And we're going to make sure that our scene's not too cluttered and there's plenty of room around our patient's head for our RSI officer to successfully intubate. So once we've done that, we're going to grab our RSI checklist and we're going to go back over our checklist and just ensure that everything we've done we can tick off on our checklist. So attaching nasal prongs without oxygen. So we've got our nasal prongs attached but no oxygen running through them yet. We are pre-oxygenating our patient with a reservoir mask at 10 litres a minute. We have our monitoring gear, so our ECG, blood pressure, SpO2 and end tidal attached. We have our monitor so it can be seen. We've left a nice space to the right hand side of the patient's head for the intubation role. We have gained bilateral IV access in the right and left ACF. We've got a running line of 0.9% sodium chloride. We've positioned our patient for optimal airway control. Towel here if we need it to pop under his head. We've placed our ETT holder under our patient's head. We have our suction, we've checked it's working and it's placed under our patient's shoulder neck area, ready to be accessed if need be. We have our manual ventilation bag here with our PEEP attached. We've obtained another set of vital signs and we can now go ahead and update the responding ICP with the patient's conditions and any update on any vitals. So once the RSI has taken place, if our RSI is successful, great, we've got our airway controlled. Obviously to RSI our patient has to have a GCS of 10 or below, so our patient's GCS was 7 and he had a poor airway, he was breath holding, grunting, etc. So that indicated our RSI. So if an RSI was to fail, we have the option of the RSI officer has the option of using a bougie, which obviously just helps to guide the intubation tube through the vocal cords. We can also, if that's failed, we can also attempt to do a cricothyroidotomy, which involves a small incision in the cricoid membrane and inserting the intubation tube through there.